Yeah, good morning also from my side. That was a short introduction. We're from Bonn and we're just like a small orthopedic practice. And we started...
Not a private practice.
Not a private practice.
Normal insurance companies coming to us.
And no center or whatever. And we started doing the MRI and the EMG thing about 2 years ago. And the talk will be about how to deal with the data and how to work with it in the daily life, because we're producing a lot of data, and it's really, really important to get that into a proper therapy and into a benefit for the patient. And this is a statement I found right in the morning actually, and that motion is the secret to diagnosis and treatment. And for me the most important thing about this is the and. It's between diagnosis and treatment. And we at the orthopedics, we see a lot of patients with pain. That's why they come to us, and we look at them at a static or in a setup where they lay on our bench, and we just investigate what the problem is, and they tell us, for example, I have the pain while I'm running. So how should we address that when we see the patient just sitting in front of us? And that's why we started thinking how to improve that, and that's why we started to do the EMG. And just a short presentation who we are and how we are working. It's the three of us. It's Marcus, me, and our colleague Julia as the doctors, and we have one sports scientist, which is Lena, right here, and one athletic trainer, Sandra, and Philip, who you met yesterday. He's also working with us as a physiotherapist. And what do? We do the EMG measuring with 6 electrodes or 6 sensors. We are happy with these 6. We don't want to do more in one measurement because we don't want to produce too much data. We do prevention screenings with athletes, but also with ambitious hobby sports athletes, especially in running. We do this in the running and gait analysis, and we always give the patients some training aspects, especially in the biofeedback training. How do we do that? The patient comes to us, see the doctors, and has a pain while running, for example, or while doing his sports. We set up a hypothesis and what the problem might be, and then we tell our sports scientist to test 3 muscle groups, or maybe just 2, it depends on the symptoms, and then afterwards they physiotherapist presents the data to us. We talk to them like we heard it last time. It's always important that you talk to each other, and then the patient comes to see us again and gets 3 exercises which he can do by his own, and we have them with an app so he can get the videos and how to reproduce it at home. And then we usually do 2 to 3 biofeedback setups to really show him what he is doing with his exercising. And after 6 to 8 weeks we do a retest, and then the same procedure again if it's not fine already, or if it's fine then he is set free and gets back to his sports. Seems to be quite simple. In daily life that's really difficult to get this done, and we brought you 3 little examples where it really worked well. And Marcus starts with an Achilles tendon problem, and this is the first one.
So this is very interesting because he's just a general insurance, and he had to pay for it by himself, so we couldn't do too many biofeedbacks, and it just shows how easy sometimes EMG can be just for the normal athlete. So he's male, 50 years, he's been doing running and sports for his whole life, and he's having Achillodynia for like 1.5 years. And also he used to run marathons and all this stuff. He's not able to run more than like 4 to 5 kilometers without getting pain. Sometimes it's better, sometimes it's worse. So it's not like a very acute tendinitis, but he's just sort of not getting around. And he's done everything. He's got a lot. He paid for physiotherapy, Stoßwelle, eccentric training, muscle training, running analysis in a running shop, changing shoes, and it just didn't work out. And so There was no specific anatomy problems, just a normal back foot. He had a slight hip tilt. He tried inlays with to get a balance, didn't work out. And you could see the typical thickness in this Achilles tendon. But you could see that he had a slight difference in the muscle of his calves. And then I asked him, I said, oh yeah, I had a very big muscle injury like 10 years ago, but worked out fine, had no problems after that, so he didn't give it too much thought. So my hypothesis was that he had like something was wrong in his calf muscles, so he couldn't run. I actually wrote medial, but I think it was lateral. So that was just a running analysis, just to have a quick overview. There was nothing special. Everything was quite similar. The standing phase, the running phase, the length of line of running, his shoes, everything was just totally normal. So if you would put him on a running track, you wouldn't see any difference at all. And then we did the EMG, of course, and what we can see up there is that his lateral gastro is doing nearly nothing regarding to his medial one on the injured right side. On the left side, it's quite even. So we talked about yesterday how much can you compare left to right, medial to lateral, but I think that is just not normal. You could see that his lateral gastro is just didn't work. The soleus on both sides, pretty even. So we said, well, we need to get this one working. So it's 80% difference from left to right lateral gastro. So 80% difference, I would say that can work out. So what we did, after the running, we just did some general testing. That's what we always do. So we try to get a setup where we say he does 10 squats, 10 one-leg squats left, 10 one-leg squats right. And we just did some 2 calf raises with both sides, then just the left side and then the right side. And what you can see is the lateral gastro is up there, left is brown and right is blue. So you can see that his lateral left gastro is doing more while up in the air than his one that is doing the push-up. And also the medial gastro is not as good as on the other side. So it's maybe a mixture of not enough lateral gastro, but also not enough muscle activity at all. So what we just basically did, so there's 88% difference lateral to left to right. So that's a huge amount. So what we did, so he's standing on our running track, or I don't know, what's the English word for Laufbahn? Treadmill, yeah, thank you. So, and he's looking at the screen, and we just said, hey, come on, try to lift your muscle activity on the lateral gastro. So that's the green one here. And you can see that if he really is trying to do it, he can do 50-50, And he just needed to figure out. I didn't say, man, do this. He just play with it. We have 1 hour of where we working with him, and the running and the diagnosis was done after 30 minutes. So he had 30 minutes of just trying to get this muscle working and just get a feeling of it. And he just went home after that, having worked out for 4 years. So he's just 30 minutes biofeedback once. So he did that for 4 weeks, and then he came back 5 weeks later, and we did the same running analysis. And you can see now on the right side that the lateral gastro is still using less, but it's much better than it was 5 weeks ago. So just small workout, very easy for him at home, and it worked out quite well. 8.5 kilometers. He was running pretty good at that time. He said, I feel good. And then we did it with 11 Ks, and we can see that he's dropping off. So that's very interesting to see that maybe you can also give him, say, try slow. The faster you go, the harder it gets you to control the muscles. So he went running, and 3 months later, I just had him in the practice, no screening again, because it's not cheap. He needs to pay for it. And he was fine, 10 kilometers with a slow run, no problems at all, after 1.5 weeks and hundreds of euros and therapy. So it's so easy. This muscle just needed to see that it can work and how it's going to work, and then it worked out quite well for him. So that's a very, very easy example. There's not much science behind that. You don't need a huge lab or many people, a lot of money. I think it cost him like 240 euros all in all, or 260, and he could do his running sport that he did for so many years. And like we had in the case before, he had this injury so long ago, and he compensated it over so long period of time, and he just didn't think that it might have been something with this injury. So the second one is, as I said before, it's Oberliga Fußballer. We just did a pre-season screening for this club because they had a lot of muscle injuries last year, and we're working with one of the trainers, and he's a personal trainer, and sort of, I don't know how he got the idea to do the screening. They just asked us whether we could do.
He was interested in EMG, and then I just suggested let's do it. And
so it was a quite easy setup. Kannst du mal auf Play drücken? So we just had the von Filipino the out of field, and we just did small same movements for all the people, and maybe just have a look at here. So that's the lateral gastro, and that's the medial, the lateral vastus and the medial vastus on the right side, and that's on the left side. And you can see that he's much more tension on the lateral vastus and nearly none on the medial. So we just did the screening. We didn't ask these guys before what's going on, but what we could see is that he had a microfracturing 3 years ago. And then we said, well, how's it going? He said, oh, actually, I had some pain for the last couple of months. I went to my surgeon, we did an MRI, everything was fine. He put some ACP in my knee. I started to do some physiotherapy. I still have my knee pain all the time. I have lateral knee pain. I said, well, we maybe know why you have it. So that was the screening parameter in data. Yeah, you can see the lateral gastro and the medial gastro on the right side. And so that's the pattern on the left side. So it's pretty even, and we can see there's a big difference. He was standing, doing nothing. The lateral vastus was firing all the time. Yeah? So that maybe was his pain. So 80% difference. So a hypothesis was after the screening, which is what we normally should not do. Maybe that's why he's having pain, because the muscles are not working. So we did some biofeedback, and I think it's always the question, can you train the medial vastus by itself? Yes, you can, pretty good. I think it's something one of you guys came up with. So you're doing it with a hip flexion. So he's got a TheraBand there, and he's using hip flexion to get muscle activity in his medial vastus. And you can see lateral, medial, he's able to sort of only use this medial vastus. And we also try on the biofeedback to give him some data about his stability. So the gluteus should be activated and some belly muscle. So we can see that he's doing it from a stable point of view. So he's not like running around and just getting some muscle activity, but doing it while he's having pelvis control. And he did that at home for a couple of weeks. And that's the data, yeah? So medial and lateral. So it's very, very easy to control only the medial part. And I think for every patellar injury, you need EMG to have a proper treatment. I don't know why it's still not working there. So 57% more medial than lateral, so that's working out quite well. So that was his first retest without, so he's not looking at the screen, so he just needs his own muscle control. And you can see, you can start it, that he's still having difficulty on the right side. Lateral is still too much, medial is not enough. On the left side is much better, but you can see that he's using his medial vastus just by doing 5 weeks of biofeedback training. And he didn't do it before this test. He just did the test out of cold blood. Can you just press play? Or was it working already?
No, I didn't do it.
So he was not able to look at his screen, so we're just doing this. And on one side, and then we did the same while using the video screen. Yeah, so he was watching on the video screen now, and you can see that he's almost able to do it like 50-50. Yeah, so he's just trying to feel the muscle and feel how the knee flexion should go, and it's working. And so that's the data. And you can see medial and lateral on the right, or medial on left and right, and lateral left and right, so it's nearly the same. So he's able to control both knees just the same, only 2 to 22% difference. And then we got him on the running takeaway with 16 Ks, and yeah, that's a running, I mean, don't look at his running type, it's maybe a bit special, but I mean, he's a good soccer player, and you can see that it's still too much lateral, but he's using both even much more, and he was not having no pain at all in this movement, which we had a lot of pain a couple of weeks ago. And yeah, still some differences, but much better. That's not all of it. So we could see that on 11 Ks, where the running speed that he's not using in his normal soccer type so much, he had more problems than on 16 Ks. And of course, we can see the foot is not working similar. He's a lot of foot rotation, so it's 2.2 degrees left and nearly 7 degrees right. So there's maybe more going around his hip, leg stability, gluteal muscle. That's the pattern on the 10 Ks. So maybe you can play that as well. So you can see that he's having much more problems there, but this is not the speed he's using when he's playing soccer. Yeah? So he doesn't feel comfortable there, he doesn't need it, maybe that's why he's not compensating so good. But yeah, that's the 10K lateral left to right. You can see a bigger difference there. So yeah, we don't have any science data there, so it would be very interesting to see the professional sport scientists to see what we have to check there. What's the difference between 16 and 10Ks? But it was good to see that the speed he needs for his soccer, that he's able to play, and we let him play. He got injured anyway, but that was because an opponent, and not because of himself. So, yeah, so two things where we can see how biofeedback is working, and easy. Like, they didn't need many sessions on biofeedback, just to getting to know how to use their muscle. And that's an easy setup, and you don't need a lot of background, and you can be young and orthopedics and still do it. So yeah, try to get to your guys. And would be very, very nice to have physiotherapists being able to do this. Yeah, how good would it be to have the first patient sending to a physiotherapist and doing like 1 week workout with EMG? It would be even much better.
Okay, and then at the end, one small case from my side to show that even the EMG can work in the rehabilitation after surgery pretty well. That's a 50 years old patient, really active in sports. He's running 10K 3 times a week, karate and cycling. He had a posterior anterior cruciate ligament reconstruction in 2011. Went quite well afterwards, and then after a twisting injury in his sports activity while doing karate, he had pain and a swelling in the knee, and he couldn't run anymore. And he was actually quite unhappy with that, and then he came to us, and then we did the MRI, of course, and then we didn't find only let's have to go back. Well, go back. Yeah, we didn't only find a just functional problem, we also find really a cartilage defect, and that's what you can see here with the red circle, and we had to fix that. So he went to surgery and we fixed his cartilage, and this is always, when you do these cartilage reconstructions, that's always a little bit difficult because every patient has his own pace afterwards, and everybody wants to come back fast, but you have to really control them that they don't do it too early. So we did an MRI 3 months after the surgery, and the cartilage really went well, but I wasn't so happy with that, that I wanted to get him back to an isokinetic testing or something, because after 3 months this cartilage is always not so stable that you want him to have full pressure on it. And but he was quite keen, and he wanted to run, and he wanted to be really back on track really fast. So we said, well, let's do an EMG and see how your muscles work, and then maybe we can give you some exercises which go pretty well and which you can do because you have a lot of control of your knee. And that's what I was talking about him. And then we found this, a lot of exercise he could do, and but nobody uses that. So we went with him on the EMG, and then this was about 5 months after the surgery, and after usually 6 months I'm happy with with one single-legged bending of the operated knee, and you can see that he is nothing doing with his medial vastus and everything doing with his lateral vastus. Of course you can guess that when you see how he is doing it. But then we told him, first, before you go running, you have to train on your medial vastus, and that's what he did for a couple of weeks with a biofeedback training, like we saw it before with the other guy. And then 7 months later, we sent him on the treadmill, and there we already saw, well, it's actually going quite well, and that looks normal. And then he was doing again his single leg squat, and after 2 months without any training with any weights, just by doing his biofeedback training with his own body weight, you can see that the medial vastus is almost as good as the lateral vastus. And then I said, well, if it's that, fine. And we did another MRI, but I didn't bring you the pictures, and the cartilage still looked good. And then we sent him back to karate and his other sport activities, and also set him again on the treadmill and increased the speed of the treadmill. That's what you can see here. We didn't have it at the below, but we started at 8 Ks and ended up at 16 Ks. And what you can see is that in the hamstrings, his biceps went down the faster he got, and his semitendinosus did all the rest. So we told him also, don't run too fast, take it easy, and go up to 8 to 10 Ks. And he's still running. He's totally happy with it. And so you can see even in rehabilitation, EMG can do a pretty good job and can guide the patients. And it's like the same, like Marcus said, it's an easy setup, and it's really shocking that orthopedics don't think about the functional muscle activity. It's common that we see patients with 3 MRIs and not with 1 EMG diagnostics, and then you do 1 EMG and you see the problem, and it's not visible in the MRI. That's it. Questions from your side?